Hello, I am Marwan Aburas. This presentation concludes the presentation regarding the 4R stages of the operational diagnosis, tooth surface assessment. We are focusing on the diagnostic features of 3 anomalies: Palatogingival Groove, dense Invaginatus, dense Evaginatus. The clinical importance of these anomalies is that they affect teeth of the cosmetic zone, anteriors and premolars. The patient is asymptomatic for years, but when they become symptomatic, the pathology is severe. The treatment is costly and complicated, and the prognosis is unpredictable. And this is why I am putting this material together. I updated my own material on it. And when I'm doing that, I discovered a lot of international information about the subject, which I like to share with you, along with my own experiences on the subject of these 3 anomalies. In this session, I will focus on, of course, the advanced symptomatic stages, As I mentioned, that's where the problem is. That's when the patient is going to come to you with a palatal groove with infection. And that's why I have selected some of these international cases. So let's begin with PGG, Palatogingival Groove. In 2010, Dr. Gu introduced a practical classification. He designed it. Type 1 will be the groove confined to the cervical zone. Type 2, the groove is in the extent all the way from the cervical zone to the apex, but the root canal remains intact. And in type 3, the groove goes all the way to the apex, but connects with the root canal and then maybe the periodontal ligament. So these 3 anomalies management, when the cases are advanced, is really difficult. And absolutely, it has to be referred to the specialist. So in that regard, you should know about them and examine your patient in the dental exam to rule out their presence. And that is a service. The second one is the dense Invaginatus. Again, I'm going to use Euler's classification. Type 1 is within the crown, not cross the CEJ. Type 2 extends beyond the CEJ, but does not connect to the root canal. It's like we call it a blind sac. It goes nowhere, only indented. And type 3, it may or may not connect with the root canal, but also may be separate. So, as I mentioned, they are rare, but you should know about them. And this is why I have selected cases from global aspect. Of course, we're going to be using the periapical radiograph and CBCT. You're going to see some beautiful examples about this area. The third category is dense Evaginatus. The third anomaly is rare, and with a prevalence of 9 to 3%. In Asian population, despite being less common, it's clinically significant because it affects, again, the occlusion. Essentially, it can fracture the anomaly during mastication, expose the pulp, and now you have a pulpal problem. So all of this you're going to be demonstrated and supported with clinical cases that I have carefully selected, performed by international educators and endodontic specialists, and put them together for your knowledge. So one of the remarkable cases that I have found in the literature again is a case in which has both dense invaginatus and dense evaginatus, so rare. But the doctors in Tehran did a beautiful job treating exactly within our guidelines. And this is why I decided to put these cases together, so you will be exposed. And all what's important is early diagnosis. So I'm putting these cases not for you to do them, but to be so keen about examining the palatal surfaces of maxillary anteriors, looking for the palatogingival groove, etc. Early detection is key in these anomalies because they can harbor bacteria. And then from the bacteria, you get caries. And then you get pulp exposure and pulp disease and periapical disease, all of that. And when you have these complications, the management becomes incredibly challenging. As I mentioned, they're all asymptomatic at early age, early stages. But left undetected, these anomalies progress. And I think it's important for you as practitioner, and after you finish that evaluation of the restorative aspect of the case, you look at color, you look at attrition, you look at cracks, you look at anomalies, and now you have basically formulated a very comprehensive view of R4, where everything meets together in the 4R operational diagnosis. This is important, and I hope I have delivered the message of comprehensiveness and excellence and accuracy and correct diagnosis in all of these presentations I put together. Thank you for listening.